We are talking, no matter what, about hypertension, so venous hypertension in this case. And if you really think about that, your answer patients with a diabetic ulcer, for example, have more than 30% of chances of having actually also venous conditions behind that. And moreover, whatever kind of patients you are treating, you are going to have more than 50% of chances of having a patient in front of you with some venous disorder that you might want to treat. So I welcome the proposal of having this nice talk about evidence-based optimal vein-leg care outside the operating room. So let's dissect the title since we are talking about surgery as well. So outside the operating room. So we will focus on what we can do before getting inside the operating room or after the operating room or eventually not to go to the operating room. And dissecting the title again, evidence-based. I really appreciated this morning the opening of this scientific initiative that focused on the importance of evidence-based. So whatever I'm going to say to you, you will see as a reference in the slides. The slides are available, and I hope you will have a deeper look later on. So, of course, introductions first. Thank you for the nice introduction. I work in the University of Ferrara, which is a nice medieval town where I hope you will join. I left all my business card at the entrance, so whoever wants to get one and stop by and visit in the future, I will be waiting for you over there. And over there is near Venice, where important colleagues of ours, like also Paracenso, and other big names like Copernicus, actually studied in the past. But today, let's focus on another kind of leg, which is, of course, the Italian leg in this case, but the venous one, dedicated to, as you can see, all the roads that are bringing back the blood flow toward the heart. So why should I bore you after such a long day with 30 minutes of venous and lymphatics? Well, I said that before. According to the evidence-based data we have more than 50% of chances of having to deal with this condition. Even more, up to 80%, according to the literature of patients, are actually having some sort of venous hypertension. But it goes without saying, if you really think about that, we don't have varicose veins on our arms. We have them on our legs. We are not quadrupeds. We are bipeds. And that's the price of the evolution, so the gravitational force. But the call that we have over here today is the one of teamwork with different specialties. Because in reality, according to the literature, less than 50% of the doctor really knows the guidelines, really know when they have to send to a specialist the patients, and really know when they should recognize in early stages, let's see if it works, the condition. This is a ginormous impact on the socioeconomic scale. 10.4% of the working days are lost because of this condition, and we don't usually think about that. And the title over here is reminding us that in the near future we will be all older. We are like getting all older as populations. We live longer. We live like with more obese patients around us that are like more sedentary. That's why the title, and that's why we should focus together in reducing the number you see over there that is talking about an increase of 60% of the procedures dedicated to this condition the last 7 years. Another talk I really enjoyed this morning was the one dedicated to hypertension that was calling that as one of the leading cause of preventable death. Well, in reality, thromboembolism is another cause of leading preventable death according to Lancet. And that's another reason why we should really be aware of how to manage these patients. But at the same time, we have venous and lymphatic involvement in this talk, because as you know, they really go together. And at the same time, the WHO, so the World Health Organization, pointed out the attention of what is called now the hidden epidemic. Lymphedema is wherever, and we still underdiagnose and undertreat that. So let's try to stop the surgeon and see how we can actually collaborate at best in the peri-procedural phase. So first of all, of course, teamwork, as I was saying, must require the patient at the center, starting from the general practitioner that knows that patients better than whatever other specialists, together with the internal medicine doctor. OBGYN, and in 1 second I will tell you why OBGYN is so important. Interventional medicine, but at the same time also rehabilitation doctors, physiatry, the nurse and the technicians, the lymphologist, as I said. Maybe we have some problems with the remote. And at the same time, nutrition and sport medicine. So 360 degrees involvement of all our colleagues. OBGYN is really important because when you start looking down at the legs of your patients, you don't have to forget to look up. A thing that we are becoming more and more aware of is what we could call the female varicocele, so the pelvic venous disorders. You know that we can have reflux with conditions like this one that a not expert eye could consider associated to lower limbs, while in reality the problem is coming up from above. So remember tomorrow when you're going back to your office, if you see a condition like this, or a condition like this where there is this vein coming down from the thigh, it's not just to be treated as a lower limb problem, but as a 360-degree problem involving also the pelvic area. 1/3 of the women are affected by chronic pelvic pain that is strictly associated to this disease. Just consider that asthma and back pain are less frequent than this condition. I'm sure you know a lot of patients that are affected by asthma and back pain. Well, you have more patients affected by pelvic venous disorder. 10% of the OBGYN visits are associated to this condition. And you see Indiana Jones over there that is trapped in the sand trap because he's not really looking at Lady Marion. So remember to look carefully at the patients you have in front of you. And you will see along this talk quite a lot of time this slide, see you at the hands-on. That is the invitation to join tomorrow the hands-on, where we'll dive a little bit deeper in these topics and the other topics you will see along this talk. Just take home the message that if you see something like this, for sure you want to think about doing a transvaginal ultrasound or at least a transabdominal ultrasound with also a linear probe so that you can eventually treat directly those leaking points with sclerotherapy. And at the same time, remember the golden rule that we all know. Cancer is guilty until proven otherwise. So a compression in the abdomen caused by a neoplasm inside the abdomen could cause this reflux. So exclude always this condition. So say that the patient is coming to you and saying, okay, we got like the diagnosis, I have pelvic venous disorder, they propose to me sclerotherapy. What should I do? Well, in reality, we are still working on this, and we have just some guidelines we published recently. And the thing they are usually saying is, let's see how it goes. But we know that just waiting and see how it goes is not always the best idea. So we recently published a paper that was looking at the effect of sclerotherapy for the treatment of this condition. And what you can say now to your patient is that in 60.4% of cases at 4 years, they will be fine with the sclerotherapy treatment if the vision analog scale, so the pain that they were perceiving before, was less than 5 out of 10. So you can say to them, like, you can try if this is the condition. If not, we want to have some more investigation. For sure, you know the I want you for US Army. Over here, I just like to have you reminding some concepts. So whenever you will see Uncle Sam over there, it's like a strong recommendation to always remember, for example, that compression in this condition could be extremely beneficial. We have preliminary data showing the potential effect of a proper compression. And I will stress out the concept of proper compression, of validated compression, as I will stress it out for venous active drugs. Indeed, talking about venous active drugs, talking about preliminary data, what you can see is that endothelium lining, because of the venous hypertension, can of course suffer for this pelvic condition, and we're talking about lower limbs. Well, we have preliminary data showing that, for example, drugs like MPFF that could increase the venous tone and lymphatic drainage while decreasing the hyperpermeability at the capillary level and improving the venous stasis could have a beneficial effect. The preliminary investigation dealing with this comes from 2007, and it's interesting because it's a crossover study. So the same population being exposed or not to the treatment showing a benefit. As the previous nice speaker said, reaching out, public venous awareness is fundamental. So there is an open access website with the foundation that Aurélien was mentioning before. I encourage you to go visiting that. It's also in Spanish. It is for your patients. It is for you. So always remember to look up, but also then look down. When we are looking down for chronic venous disease, we all know we have a reflux, so the blood is going in the wrong direction, and we have to fix the situation. And we have to fix that as soon as possible, because we know that with a different velocity from patients to patients based on the risk factors, the stairs goes like this. We have a C1 condition that we saw before is present in more than 80% of cases. That goes then to C2 with the varices with edema, and then an important step, because it's really difficult from that point to go down from that stairs. So the hyperpigmentation associated with the venous hypertension, once again, that leads the iron deposits to extravasate in the tissue. C5 is the no turning back point. Once you are like C5, you will be C5 all your life, because that's an unhealed answer. And that's to stress out the importance of arriving there before you get to a step you cannot go down anymore. And then, as you know, open answer. So Uncle Sam is saying just stop the patient before he goes that road, particularly before arriving to the fourth steps. So what should we do for an evidence-based appropriate treatment? Of course, detailed history collection, getting immediately into action. Whatever our specialty is, we should all be aware of the tools we all have. And at the same time, knowing the best operative option if our patients are asking us what we think you should do in terms of surgical procedure. I like this joke. I'm sorry, the X-ray or the CT scan is broken, so I'm forced to take your anamnesis and your history. Of course, in this modern age, we are not used so much to look at signs and symptoms, something we are losing a little bit, and maybe we should focus a little bit more. We know it's fundamental to give time to the patient. We know it's not always fun to do that, but at the same time, it's really important because it will allow us to focus, of course, on the main thing, which is always being sure that there are like no allergies, but also the importance of obesity. Calculating the BMI to understand the risk factors these patients have of having venous symptoms despite the absence of reflux. So remember that obesity per se is a cause of venous hypertension. So you could not detect any flow that is pathological, but when the patient, for example, is sitting, the abdominal mass is going to compress the vein, so giving you venous hypertension, and you will have indeed patients without reflux, with hyperpigmentation, and you are not able to find the reflux. Look at the BMI, they could be obese. Moving forward, drug history, also to be sure that some colleagues didn't do the mistake we still see too much. Using diuretics for swelling, we know it's a lot of time inappropriate in these patients. As we know that using antibiotics for an ulcer is a lot of time inappropriate. The other thing we should know is if the patient, particularly, of course, if female, is under hormonal treatment. And it's good to know that hormonal replacement is increasing the risk, it's true, of DVTs. You see over there the odds ratio 1.58, but it's actually quite a fake news that hormonal contraceptive can actually increase the risk of chronic venous disease. That is a thing that is usually said, but it's actually not true. And we recently published a paper showing the importance of having a detailed analysis of the ultrasound, also of the deep venous system. So a common mistake you can see is that they are giving you a report where there is just a superficial system. They have also to specify the deep system in these reports because this could be associated with a risk that is 5 times higher of developing recurrences if you're like missing the valve that you see there in the ilofemoral tract. It's really important to know if they are using compression stockings and if they are using the appropriate ones, because in reality, compression stocking could reduce the recurrence of the condition from 71 up to 6%. And it has to be, of course, the validated compression. And if it is validated, it has been reported now in the guidelines also, that even if they are not affected by disease, but they are at risk of developing swelling, then you should put proper compression. And if the patient is saying to you that compression is not useful or is like really uncomfortable, just remind that according to the literature, 63% of cases are not compliant because the stocking was wrongly prescribed, not the right size, not the right type. So remember that prescribing a stocking requires the same attention that you put when you're prescribing a drug, because it is indeed as powerful potentially as a drug. So venous symptoms at the same time could be present without an instrumental evidence, as I said before. And this is particularly true for the professional venous hypertension. So think about venous hypertension also in patients that are sitting for more, for example, than 30 minutes. We demonstrated in an investigation that you have already venous hypertension going on over there. So when was like somebody asking to get just stand up because already 30 minutes sitting? And And so moving forward, also the sport activity of these patients is pretty important because on one side we have the fake news of over-treatment. So if you think about like sport varices, they're like not varices, like they're simply dilated veins. At the same time, you could have conditions like this one that, differently from the one before, is actually pathological, as you can see. So you have to be able to discriminate the two different conditions. And another very important thing is to look down at how we put down the foot. Because in this moment, I could push very well my foot pump and stimulate my venous return, or I could put my foot down in a bad way and increase by 4 times the risk of developing a reflux. And also for this, we will see each other, I hope, at the end on, to go a little bit deeper, as we will do for the risk factors, so we will discuss about this tomorrow. I just want to point out the importance of the answer, because we are like more or less 300 people over here. This means that for sure, unfortunately, 3 of us will experience an answer lesion that will have to be evaluated not just in the lesion per se, but also in the perilesional skin, in the full limb condition, in also the other limb condition, because you see that the scenario could change a lot. You see over here a lot. You see, for example, the wrong posture of the foot. You see that there is lymphedema. You see that there is like not a very good hygiene. So these things are to be noticed. Of course, this is like the mirror image. I can see that now like you're getting a little bit tired, but just remember that 2% of people over 80 years old can have this condition, and that is recurrent in 69% of cases. And still talking about diabetes, you will see that we are not so good in managing both the diabetic ones and the venous ones. Just know that we can do so much better because, for example, compression therapy, according to the literature, has been applied in these kind of patients just in 58.7% of cases. When it was applied, there was pain, 82.9% of cases. Only 1/3 of the patients actually received a prescription, and of these ones, just 52% took the medication. So that in the end, you see that at 6 months, this is the percentage of the answers we are able to cure. In the leg, 50% still open. In the foot, 30%. So we can just do it better, I think, in the management of these patients that both specialties of ours are managing. So, of course, get the detailed history, as I was saying before. Listen carefully to the kind of symptoms because they can be really specific. So, like, are they true or not? Like, are they really well described or not? And if they have no symptoms, don't think that there is no disease, because symptoms could be absent, but venous hypertension could be already there. So also for this, we will see each other tomorrow at the end on. While I just like you to remind you what Snoopy is saying over here. When you write to a girl, you have to be more specific. Then I miss you at 8:15, 11:45, and like, so be specific when you are describing the kind of symptoms the patient has. That could be related to venous hypertension or not, but surely to the quality of life. This is an interesting paper about MPFF that is actually showing that even if there was no significant reflux detected, in reality there was venous hypertension that was managed properly with the right prescription. So get the right physical exam, look at the leg as a second point, and also for this we will see each other tomorrow, if the slides goes on. Can you help me out from there, guys? Okay. Again. And then get into action. So since we are getting to the closing part of the lesson, well, just remember the numbers. 1 person out of 130 are actually affected by a thrombosis. If you really think about that, if you sum up HIV, car accidents, and breast cancers all together, they are still less of the number of victims you have of thrombosis. So you understand the importance of being involved with this. Go to the same website and you will see that you have evidence-based educational questionnaires, again, also in Spanish, for your patients and for the colleagues. Same thing for the educational video. Now, you will see this funny T-shirt that Claudia has that is saying, never kill a friend, never treat a stranger. This one is actually Caprini. Caprini, maybe you have heard him. He's like the most famous guy in thrombosis. He's a dear friend, and he did something great for all of us. In his website, you can download the Caprini score that is giving you exactly the risk of your patient. So the suggestion is simply print it, stick it to your wall, and every day when you see a patient, just have a look at that, because it will give you the risk that the patient has, particularly if he's going, for example, under some surgical procedure. And the interesting thing is that if the patient is having a higher risk of hemorrhage, in reality, even compression alone is considered enough to reduce significantly the risk of DVT. So be sure that the patient is getting the right procedure is another important suggestion. So when they will come back to you and say, the other doctor suggests me to do this, what should I do? Well, of course, when there is a reflux in the vein, they usually suggest to take away the vein. But in reality, it's true that we have so many different appealing new devices, always more and more mini-invasive for our patients. But all these devices are actually based on the same strategy, because either you remove that surgically, or you burn it with a laser, or with radiofrequency, or you vaporize that, or you glue that, or you torture that with whatever kind of device you want, you are still applying the same technique that was first described by the gentleman over here, that is Albucacis of Cordoba, the first one who described the surgical removal of the saphenous vein by a stripping procedure. So in the metaphor is like giving brand new weapons to the army, instructing the army to move always in the same direction. Cochrane demonstrated in 2015 that you can do something better when you are like closing the leaking point in the specific point that is reflexing, not ablating all the rest. So the take-home message is simply know that you can spare the vast majority of the venous system, acting just on the part that has the leaking reflux. And just remember to the patients what I said at the beginning of the talk. We don't have varicose veins on our arms, we have them on our limbs. So either we start walking downward on our arms, or venous hypertension will be always there. So think about this when you can get into action with proper compression, proper venous active drugs, proper lifestyle. Consider that the recurrence goes up to 80%, even if you have already treated the reflux. So going toward the end, how to act now, in your case specifically, outside the operating room. Remember always the DVT risk. Consider proper compression and validated venous active drugs, and a proper also lymphatic management. So in terms of the patients you know, for example, if your patient is going to fly for more than 3 hours and could eventually enjoy then some protection in terms of edema or in terms of DVTs. This is a nice study we did where we look at what happened when you're like flying with a normal socks rather than using a proper graduated compression. And what we demonstrated is that after 4 hours of flight, you have already a significant edema in a healthy subject that you can control with proper compression. Same thing if you have a subject that is working in a prolonged sedentary or standing up position. Diving a little bit more into the venous active drugs topic, venous hypertension basically is really simple. It's the internal venous pressure minus like the external venous pressure, and you can act on both sides, right? So there is a vicious circle clearly. As you can see over here, you start from the venous hypertension, you have a bone distortion and leakage. This is going to create the shear stress on the endothelium lining. They will give you the inflammation, the skin disorders, and the ulceration. This will create then other bone damage and endothelium and wall changes that will aggravate the reflux, that at the same time will overload the lymphatic system so that you will have another vicious circle that is increasing again hypertension, and then you start on the circle again. So on the valve reflex, you can act, again, in the operating room, for example, closing the leaking point. And we demonstrated with this paper of ours that the inflammatory markers are going to be reduced in this way. You can act at the same time on the dilation, and it has been demonstrated that proper compression is acting indeed on the inflammatory markers as well. And you can act on the venous wall. Now, the venous wall means biosignaling, so how a physical force, like the shear stress, is translated into a biochemical message. That is a message that will lead to smooth muscle cells hypertrophy, to an endothelial cells and matrix the arrangement, and to the release of many inflammatory markers, right? So the first thing that happens when you're like having a shear stress that is altered is that the receptors that are there, like the glycocalyx, are going to be ruined, so that you have an alteration in the transmission of the signal there. And for this reason, you have a rationale in drugs like suradoxide that are able to protect this lining. In terms of venous active drugs, though, it is evidence-based that the vast majority of literature is on MPFF. It is demonstrated in a healthy way with many investigations that the drug is able to control many aspects of this inflammation, starting from the venous tone, and you can dive into this literature to really understand how it works. It can block the adhesion of the leukocytes that are like in this way able to roll away rather than staying in the inflammatory area. It is able at the same time, if we can move forward, to act directly on the inflammatory mediators, acting also on the capillary permeability, and in the end also in the lab it has been demonstrated it has some action on the lymphatic contractility. So that is a very interesting future topic of research, I think, to see the interactions between lymphatics and veins. So you have nice papers like this one that are like summing up the main validated venous active drugs that you have. Basically, it's MPFF, rhodosides, calcium tobacillate, and sulodexide. You can see the clinical benefits reported over there. We recently had a review on all these topics because we were like kind of impressed by this Cochrane that is showing you that there is a moderate quality evidence that you can have an improvement in edema and in the CVD signs and symptoms. But the thing that we didn't really like so much is that this Cochrane is putting together apples and oranges because you have like so many different drugs involved. So in this document we recently published, we pointed out the importance of keeping venous active drugs separated when you're analyzing them. Because if you are like looking at the recommendations internationally and they put all together, it's like putting a good Italian wine with a not like so good Italian wine, another wine from another country, and it will become like kind of a mess in the evaluation of wine per se, okay? And you can find the detail of this. It's an open access document that has been produced after the last meeting of the Vivian Foundation. It is on phlebology, and it is dealing with both the evaluation for the venous symptoms and the ulceration, concluding that indeed the two most validated are like MPFF, and sulodexide, of course, with MPFF having significant more validation in terms of the effects. So, moving to the end, the hidden epidemic. We were saying before lymphedema is like extremely frequent, also considering the fact that 80% of the population worldwide is obese. And this is indeed affecting also the fat component, so extremely frequent. What I will just say over here is that we have to be aware of that. We have to be able to recognize that. We don't have to simply say, oh, like you're fat and that's it. Very probably there is a lymphedema or even a lipedema component behind the conditions that we have to treat. So the suggestion is be sure to indicate at least an ultrasound examination. This is a paper we recently published specifically for the edema also of the upper limb. There are like more advanced investigation you can use, but I don't want to dive into this over here. Just remember that if it is involving the lymphatics, it is involving also the veins, as demonstrated over here, and vice versa. So remember that a proper compression is fundamental, and that remember that a very powerful tool is the nice C we have in front of us, because water is per se a natural compression system that can help your patients a lot. So the suggestion is go inside the water environment up to the navel because you want the hydrostatic pressure created by the water. And we have a paper on this that we will discuss tomorrow. It is published on phlebology. And you can have a download for free of that and using it with your patients. Then concluding, the last message is remember that lymphedema and a dirty skin is not cool. It's fundamental that when you see these kind of patients, you think about also the potential venous involvement, the potential venous hypertension behind that condition, and always remember that a very easy thing that is very important is like to keep the skin clean. So teamwork, as I was saying at the very beginning, so I take this chance to say that in life it's not just where you go, but also who you travel with. So I reciprocate the nice introduction that I had from Aurélien, thanking all the group of Servier who has been working with us in the last humanitarian mission that has been also an educational mission, open to all the kind of doctors who wants to join us. The next stop will be in Guatemala. You will see, hopefully by yourself. I think you have, like in your material, also the 10 golden rules we have been giving on this topic. They are all based on the evidence, so feel free to have a look at that and hopefully using them. And then I will see you at the hands-on, and I hope I will see you also in the next adventure of the Viewing Foundation that will be in Dubai during the Expo. We are really caring about fake news because it has been published in this paper that up to 40% of the medical websites are including fake news that are like shared 450,000 times. So I think it's our responsibility as societies, scientific societies, to stop this. And so we will be all together in a nice place discussing about how to communicate venous and lymphatic disease to patients. Thank you so much.